I'm Suzanne Levely. I'm the Interim Associate Dean for Research. We're really thrilled about our program today, and I think everyone will find it very valuable and enriching for students and faculty and all of our guests. I'd like to invite our Dean, Dr. Kulwicki, to the podium for some opening remarks.
Thank you, Suzanne. Good morning. Did you have a healthy breakfast? Good. Distinguished speakers, Dr. Suzanne Smeltzer and Dr. Bernard Gutin, Provost Langley, ladies and gentlemen. It is my great pleasure to welcome you to this event with the 29th Anniversary Celebration Committee and to welcome all of you to Boston's great public university, the University of Massachusetts, Boston. It is wonderful to be here with you as we mark the 29th Research Day of the College of Nursing and Health Sciences at the university. I am especially grateful to the 29th Research Day Committee for their volunteer leadership and their efforts in putting this event together. Thanks to them, we cannot have had a Research Day without their hard work. So all of you who were on that committee and the volunteers, would you stand up and be recognized, and let's give them a hand for the wonderful work that they do. I also want to thank Dr. Suzanne Levely, the Interim Associate Dean for Research, for leading the effort. Thank you, Suzanne. As Neil Armstrong stated, research is creating new knowledge. Therefore, we are here to listen and see the new knowledge that is created by all the presenters. We are also here today to celebrate the importance of research, as Albert Einstein stated. If we knew what it was we were doing, it would not be called research, would it? And as the Roman Stoic poet Flaccus said, your knowledge is nothing when no one else knows that you know it except you. So be prepared to see, listen, and sometimes feel and experience the knowledge our speakers, faculty, students, and students have created. Chief Kara stated, research has shown that it takes 31 days of conscious effort to make or break a habit. That means if one practices something consistently for 31 days, on the 32nd day, it does become a habit. So keep on counting your days. Information has been internalized then into behavioral change, which is called transformation. Today, our speakers, faculty, students, and partners will provide us with examples of how they have been transformed and hopefully transforming us with their creation. As you know, the mission of the College of Nursing and Health Sciences is to teach, conduct research, and serve the community. Our college has been recognized for promoting excellence in the areas of education, research, and practice. Our vision is to reach the pinnacles of academic, professional, and research excellence as we devote our attention to the increasing health needs of diverse and underserved populations. We are here to showcase our students, faculties, partners, research, and to demonstrate our strong commitment to our university and college mission. And finally, on a lighter note, I want to conclude my remarks by Bill Vaughn's quote, "Money won't buy you happiness, but it will pay the salaries of a large research staff to study the problem." And before I hand over to our Provost, Winston Langley, I want to say once more, on behalf of the CNHS Research Organizing Committee, welcome. It's a pleasure to see so many of you here. Now it is my distinct pleasure to introduce Provost Winston Langley. Provost Langley.
Thank you, Dean Kulwicki and Professor Suzanne Levely. And thanks to the faculty the students, staff, and partners, to the two departments which constitute the college for the very good work in preparing this 29th Annual Research Day event. And thank you for having me among you. The revered Greek philosopher Socrates argued and taught that the unexamined life is not worth living. And he said that, I think, with the understanding that life and the right to life, they have a certain fundamental moral claim of the species. The unhealthful life is not worth living either. And indeed, life itself is not possible without health. In short, the right to health is implied as part of the grounding in which the right to life is constructed. And we know something about the right to life as an entitlement to all human beings. I'd like to share with you Article 12 of the 1966 International Covenant, and I emphasize covenant. The term was used. They did not want the term treaty. They didn't want the term international convention. They did not want a protocol. They didn't want a declaration. They wanted a covenant as a sacred pledge among members of the global community. The covenant and economic, social, and cultural rights asserts that states should recognize the right of everyone to the enjoyment of the highest attainable standard of physical and mental health. And Article 9 of the 1976 Universal Declaration of the Rights of Peoples and States said, scientific and technical progress being part of the common heritage of humankind, every people has a right to participate in that scientific and technical progress. Peoples is used here to underline what we'd call public health, as distinct from an individual's health. What we're doing here today is an affirmation of the international and global commitment made in the last century. Nothing less. You are saying that health care is so important that approaches to it should not go unexamined. That part of that examination must be the bringing of evidence-based decisions, which will help us deal with beliefs, preferences, and unreviewed practices. You're also dealing with the heritage of great universities, portions of whose purposes are to repair what has been corrupted, whether in practice, in thinking, or otherwise. Redirecting the paths we collectively travel, reconsidering the quality of evidence, reconstructing the corpus of knowledge, and discovering formerly unknown areas of inquiry, and rediscovering part of what we have come to call human wholeness. Our keynote speakers today, Dr. Suzanne Smeltzer and Bernard Gutin, the work of students, the faculty and staff, are all in pursuit of the evidence that will inform the best approaches to health in nursing, in exercise and health sciences, and in answering and being responsive to the right of peoples. For your dedication, your discipline, your sacrifices, welcome to our 29th Annual Research Day, and welcome to our common task. Thank you.
Dr. Joanne Mulready-Schick, and on behalf of Dr. Rosanna DeMarco and the nursing department, it's my pleasure to introduce our first keynote speaker, Dr. Suzanne Smeltzer. Dr. Smeltzer is professor and director of the Center for Nursing Research at Villanova University College of Nursing in Pennsylvania. Dr. Smeltzer received her baccalaureate nursing degree from St. Louis University, her master's from Texas Women's University, and her doctorate in education from the University of Pennsylvania. She completed a 2-year postdoc fellowship as a Robert Wood Johnson Clinical Nurse Scholar at the University of Rochester. Dr. Smeltzer's conducted research related to respiratory issues in people with multiple sclerosis and pregnancy, and health issues of women with disabilities. She's published her research in a variety of nursing and health science journals, and it was lead author of Bruner and Suddarth's textbook of med-surg nursing. Now, for me, those textbooks, those med-surg textbooks are like this, and in my time, you carried them like this, and then, of course, we went to backpacks, then to the rollies. Now, thankfully, for prevention of back injury, e-learning platforms, right? So, thank you for all of those contributions. Dr. Smeltzer has served as a member of several state and national task forces developing curricula for training healthcare providers on topics including care of people with disabilities. As a founding member of the board of the Alliance for Disability and Healthcare Education, was recently this coalition's president. Her research has been funded by NIH, the National MS Society, Robert Wood Johnson Foundation, Bristol Myers Squibb Foundation, and amongst many others. Please read about her many awards, and her accolades include being a fellow in the American Academy of Nursing, past president of the Eastern Nursing Research Society and the Alliance for Disability and Healthcare Education, chair of the Clinical Advisory Committee of the Greater Delaware Valley chapter of the National MS Society. And for me personally, she was one of the most inspiring faculty I had in my graduate clinical nurse specialist program at Penn, and so, which was just a few years ago, right? So we're honored by Dr. Smeltzer's presence with us today and her presentation on a research trajectory related to disability. Dr. Smeltzer.
Thank you very much. Thank you, Joanne, for that very generous introduction. Let me tell you what we're going to do in the time that I have this morning. I'm going to talk a little bit about the epidemiology of disability in the U.S., definitions and types of disability, basically to get us on the same stage and within the right context. I'm also going to talk about research, practice, and education issues related to disability, and then to describe one trajectory in research, practice, and education. It happens to be mine. Just to put us again into, on the same page, one of the things that I have found to be essential in many groups, maybe not here, but in many groups, is basically to ask and answer the question, why is disability important, and why is disability combined with health important? And I think this slide sort of says it pretty well before we get into some of the nitty-gritty. Compared with individuals without disability, and I'm not going to read all of these, but I'm just going to highlight a couple of them, people with disabilities experience difficulties or delays in getting the health care that they need. They tend not to have an annual, or less likely to have annual dental exams, mammograms, pap smears, less likely to engage in physical fitness activities, more likely to use tobacco, more likely to be overweight or obese, more likely to have high blood pressure, et cetera, et cetera, et cetera. A couple of definitions. There are in the federal government, I have heard it said that there are at least 129 different definitions of disability that are used. No wonder we have difficulty with the, the health system, particularly from the national level. But the Americans with Disabilities Act definition is one that I think most of us can at least relate to. The ADA defines disability as a physical or mental impairment that substantially limits one or more major life activities, a record or history of such an impairment, or is regarded or perceived by others as having such an impairment. Now let me say just a thing or two about the ADA. A lot of people say, well, the United States should be fine relative to disabilities and health care and all kinds of other services, because after all, we have the ADA. We have the Americans with Disabilities Act. Yes, we do. The Americans with Disabilities Act, however, is not enforced very strongly. In other words, it doesn't have teeth to it. What it takes, typically, for the ADA to be enforced is for people to initiate lawsuits. And if you have a disability and if you're encountering some difficulty in getting health care or some other kinds of services, first of all, you have a lower income. It's not easy to initiate a lawsuit, particularly when you don't have any idea what the chances are that you're going to be successful. So even though we have such an act, the ADA, and have had it since 1990, know that it is not a panacea and has not answered all the issues or taken care of all the issues that we have or people with disabilities have. As I say, there are a bunch of definitions of disability out there, but what I want to share for a second is a definition which I'm almost embarrassed to admit that I just learned about 2 or 3 years ago. I should have done this 20 years ago because it sort of says it all. The ICN, which is part of the World Health Organization, describes disability not very differently than the ADA. It's a physical, mental, sensory, or social impairment that in the long term adversely affects one's ability to carry out normal day-to-day activities. Now, the next bullet, or not bullet, but the next sort of little section and the next slide shows you why I'm embarrassed that I did not look at this sooner. The ICN supports programs to integrate people with disabilities in all aspects of life, in the family, school, workplace, and community. And that means health as well, and education for that matter. The ICN position statement goes on to say that nurses are expected to have an understanding of the particular problems faced by people with disabilities and their families, and to have advocacy skills and a knowledge of the programs and resources in their community. Nurses are expected to assist, support, and advocate for people with disabilities and their families to access education, information, and support services that allow them to lead fulfilling lives. That sounds perfect. It says exactly what nurses should be doing relative to caring for people with disabilities. The interesting thing is that no other nursing organization, perhaps with the exception of the Rehab Nurses Association or a very specific organization that focuses on disability, and that's typically in a pediatrics setting, no other nursing organization even uses the word disability in their statements. In other words, here's the ICN saying this, and here are all the nursing education and practice organizations, and there's no connection related to the topic of disability, and we're going to come back to that. This is not a definition, but I sort of use it as one. Kirshner and Curry are two physiatrists, and in the year 2009, they published an article in JAMA, and this is what they said. Disability is a universal experience that affects nearly everyone without exception at some time in their lives. What that means is you, me, and everybody else is going to have some experience with disability at some point. And one of the things that we need as professionals is to make sure that our nurses and other healthcare providers going forward know how to care for people with disabilities in a knowledgeable and sensitive way. And again, I will come back to that theme in a few minutes. Prevalence of disabilities, I often ask a group, how many people do you think there are in the United States with disabilities? And I hear people say, oh, maybe 100,000. And I say, go up a little higher. And they say, oh, maybe 1 million. The highest number I've ever gotten back is 20 million. In truth, there are 60 million people in the United States and 1 billion people worldwide living with one or more disabilities. That's 1 in every 4. Some people say 1 in every 5. Individuals who lives with 1 or more disabilities. And as you can see from the numbers on the bottom of the slide, this doesn't just affect the elderly, which is what a lot of people believe. It affects people at all walks of life. But there are some groups where it's ignored more than others. And again, we'll talk about that. Just a couple of overall comments relative to disabilities, and again, I'm not going to go through these in any detail, but disabilities vary in severity, ranging from very mild to very severe, to the point where technology is needed for somebody's very survival. Disabilities vary in type, ranging from physical disabilities to communication disabilities, cognitive and psychiatric and sensory disabilities, anywhere in between. Disability varies in visibility. It could be that the disability is not visible to anyone. There are some people who have a disability where if you are informed or particularly sensitive, in terms of your assessment skills, you might say, yes, that person has a disability, when somebody else might not recognize it. And then there are disabilities where they are visible to everybody and anyone. Another characteristic of disability, not disabilities per se, is that the population of people with disabilities is increasing in size. Because of advances in healthcare, the survival of people with disabilities across the lifespan, such as very low birth weight babies, not too many years ago, they didn't survive, and they are surviving. Even if they weigh just about a pound at birth. They're surviving, but many times they survive and have lifelong disabilities as a consequence. There are adults with something called who are chronically critically ill. An increase in the number of people with chronic disease, in part because of the lifestyle of people in the United States, but also because of aging of the population. There is another factor which I'm sure is close to the heart of people in Boston, is the increased survival of those with trauma. ENRS was here in Boston the year of the Boston bombing, the marathon bombing, and there were 3 people killed, there were over 200 people injured, and I think it was something like 28 people immediately became amputees, with disabilities, obviously. The train crash yesterday, a train, by the way, that I take on a regular basis, scares the daylights out of me. But anyway, that train wreck yesterday, there were 7 people killed, there were over 200 people injured. And what do we hear about? We hear about the number of deaths. That's huge, 7. Should not have happened. What we don't hear about afterwards is what happens to those 200 people, some of whom will recover completely, some of whom will have disabilities for the rest of their lives. And then the other last example is the earthquake in Nepal. The last figure I heard was close to 9,000 people killed. There are many, excuse me, many more people who have no doubt suffered injuries. Many of them are likely to lead to loss of limbs and chronic illness and disability from that point forward. So there is something that we need to address going forward. And as I mentioned before, there's an increased number of elderly and frail elderly. Okay, I'm going to talk in one case very quickly, in the other case a little slower, but not much. 2 unrelated research trajectories in disability, which together I call my trajectory. On the left-hand side, respiratory issues, and I'm going to be talking about that again quickly, but I will talk about it, in which I collaborated with neurologists and pulmonologists, funded by the MS Society, thanks Joanne, the MS Society and NIH. Yeah, is that open? Okay, that's my problem, I can't open it. So that's one, sort of one leg or one limb, if you will, of this research trajectory. And the other, and I'll tell you how this happened, is related to health issues of women with disabilities. Again, I've collaborated with health services researchers, biobehavioral researchers, a number of nursing colleagues, et cetera. We had funding from Bristol Myers, NIH, Inglis. Inglis is a wheelchair community in the Philadelphia area. ASPE, which you probably never heard of, is called the Association of Standardized Patient Educators, and the National League for Nursing. Even though these are disparate, the goal for me is basically the same, and that is to improve the health and healthcare of people with disabilities, including nursing care, because that's what I'm about, as opposed to some of the other disciplines. And again, you're going to see that slide again very shortly. So let me just very quickly go through this left side of that slide in terms of the respiratory pieces. When I was a Robert Wood Johnson clinical scholar at the University of Rochester, I ended up working with 2 neurologists and a pulmonologist, and one of the things that we did was to examine pulmonary function and respiratory function in patients with MS. We had 25 patients with clinically definite MS who had pulmonary function testing with the addition of maximal inspiratory and expiratory pressures. These pressures are not part of routine pulmonary function tests. One of the things, the major thing that we found was that most pulmonary function test results were normal in patients who were ambulatory, but they were decreased in patients with severe disability. But the more important piece of that is that although inspiratory muscle strength was preserved in most patients, expiratory muscle weakness was decreased. This has never been reported before we did, has been since then in other studies. It had not been reported. The significance of this expiratory muscle weakness is that it leads to a weak cough and increased risk of aspiration, which is a major health issue for people, with MS. For many, many years, it was the most common cause of death. Now it's infection. After my Robert Wood Johnson fellowship, I was at Rutgers and linked up with 2 more neurologists and a pulmonologist. And we took a look at a couple of different things all related to respiratory issues in people with MS. Again, we put them through some pulmonary function tests, including the measures of muscle strength. I also took from the previous study, looking at the results of some of the non-pulmonary function test results, and put together a 4-item clinical index of pulmonary dysfunction in MS. And one of the things that I was interested in was how reliable, valid, specific, and sensitive this little 4-item index is in predicting expiratory muscle weakness when nobody had ever heard of expiratory muscle weakness before in people with MS. Again, they had pulmonary function tests. We administered the 4-item index. What we found was that this little 4-item index predicted the presence or the absence of severe expiratory muscle weakness in 80% of the participants. It was better than the clinical assessment of the neurologist and better than standard pulmonary function tests. This could be useful in identifying patients at risk earlier in the course of MS, but it also led to subsequent research. With an NIH grant in mind, one of the things we realized was that we needed to make sure that we had good measurements, reliable and valid measurements of maximal respiratory pressures in MS. So we had 72 people with MS, 61 healthy control groups, and obtained measures of inspiratory and expiratory pressures over a 4-week period, 4 sets each time over a 4-week period. I drove all over New Jersey. I live in New Jersey, and I learned about parts of New Jersey that I never knew existed before. Put something like 10,000 miles on my car, and I usually don't put any miles on my car because I'm a train taker. So I did a lot of traveling around because the MS patients were measured in their homes. The results showed that you take healthy control subjects and have them do these inspiratory and expiratory pressure measurements. One practice session, you can get an adequate and accurate baseline. With people with MS, though, they needed 3 practice sessions, in other words, over 3 weeks. And by the 4th week, you had a pretty good, reliable baseline. If we had started, if we had not done this, we might have said in our subsequent work, let's measure the pulmonary inspiratory and expiratory pressure, then we're going to do some training, and we're going to see if they got better in terms of the muscle strength. They would have, because now they have had some practice. And if we had not established ahead of time that baseline was not established until 4 weeks, we then were able to include that in the subsequent study that we did. So the next study was, is this the one? Yeah, this is the one. Expiratory muscle training in patients with MS. We did a randomized clinical trial of expiratory muscle strength in 20 patients. This was a pilot study, at least that was the intent. One group received expiratory training, and the control group received sham training for 3 months. What we found was that we could demonstrate a significant increase in expiratory muscle strength after 3 months of training with the real training as opposed to the sham training. There was no change in inspiratory strength. One of the things which is characteristic of the expiratory muscles is that they're passive. And so, as you take breaths, you're exercising your inspiratory muscles, but that doesn't do much for your expiratory muscles, and that's what was affected in these individuals, and that's what increases the risk of aspiration and pneumonias in people with disabilities. The lack of cough, strong cough, and expiratory muscle weakness. So we were all set. We had the reliability and the validity. We knew we could increase the strength of expiratory muscles, and so now we're going to go for the NIH grant. So we submitted 2 grants to NIH. The purpose was to test the effect of expiratory muscle training on the mechanical effectiveness of cough non-invasively. As I was saying to the other speaker in the taxi on the way over, the current measure of cough effectiveness requires you to swallow balloons. You can get people to do that once. You can't get them to do it more than that. In fact, I did this. I swallowed the balloons in order to get an idea what what this was going to be like for our, for the patients that we were going to try to recruit. And I said to Mark, the pulmonary physician, as he's putting these balloons down, I said to him, Mark, you better get this right, because I'm only doing it once. And so I knew that if I felt that way, that people with MS were going to feel the same way. And I also knew that the neurologists, who would be the source of our patients, they didn't want to do anything that was going to ruin things for them coming after these patients for participation in subsequent studies. So we needed something non-invasive. We were never able to identify something non-invasive. And somebody from NIH actually called me after the second grant and said, this is what you need to do in order to fix this. And I said, I know, but we can't because we need a non-invasive way of doing it. So this essentially became the end of the road in terms of respiratory, the respiratory issue. Now, this I think is a lesson for, or could be a lesson for anybody, a researcher, a student, or whomever. It is always a good idea to have more than one thing going at a time. Because if you only have one thing going at a time in terms of research, and if you hit the end of the road, as we did in this study, you have nothing else to carry you forward. So this is the same slide I started with earlier. One of the things that's missing from this, though, is what you see in this slide, this little red arrow. When I was involved in the study looking at respiratory issues in MS at the University of Rochester, one of the neurologists came to me and he said that he was going to work with one of the obstetricians in order to take a look at the issue of pregnancy in women with MS. And did I want to work with him? Well, I've always said to audiences, when somebody asks you that, say yes until you find out otherwise. Don't say no and then find out afterwards that you regret it. Because it's an opportunity. And this, to me, was not only an opportunity, it was being a good fellow or a good graduate student or whatever. Say yes when opportunities come your way. So in the course of this study, which was focusing specifically on the effect of pregnancy in MS, I was interacting with the women who were coming in for that study and realized very, very quickly that these women had all kinds of questions and nobody knew any answers to them. So that red arrow signifies how I was involved with this group of neurologists who one of them ended up also looking at pregnancy in MS, but his focus was on the MS side of it, and that gave me entree into looking at something which then became my subsequent research program. So the study that the neurologist and the obstetrician, and me as, the third person, was looking at the effect of pregnancy on MS. There were 8 women followed during pregnancy. The purpose was to see what happens in terms of the course of MS and pregnancy, and also to see if one could identify what is it about pregnancy that keeps women with MS more symptom-free, if you will. They have fewer exacerbations, their symptoms tend to decrease during pregnancy. So what is it about pregnancy that allows that to happen? The good news is that I was able to, spin off on this for my research. The bad news was that we never did identify what that difference was. 7 of the 8 women did have exacerbations within 7 weeks of delivery. Most of them returned to baseline in terms of their MS severity, but we still were unable to identify specifically what the issue was, that protected them during pregnancy. So then I got into, interviewing some of these women about what were the concerns of pregnant women with MS. So there were 15 women who participated in a qualitative study using individual interviews about their concerns related to pregnancy within the context of MS. Women did have concerns similar to those of pregnant women without MS. But they were able, and this was interesting to me, they were able to say, oh no, that's not MS related, this is what other people have with pregnancy. They were able, at least from their perspective, to be able to discern what was MS related and what was not. Because that's always a question that comes up, in a discussion, in publication. Well, how do you know that these symptoms are not MS related? The women knew, or at least they claimed they knew. One of the things that we found was that, or I found, because I was not collaborating with anybody on this, is that women with MS found all kinds of conflicting information. Most of these people were seen by neurologists. They were also being seen by obstetricians. They would ask their neurologist about what's the effect of pregnancy on MS. The neurologist would say, I don't know, ask your obstetrician. They would talk to the obstetrician. The obstetrician would say, I don't know, ask your neurologist. And so they were sort of caught between this situation. The unpredictability of MS and uncertainty permeated many of the concerns that they had. This resulted in me getting very interested in the topic of health issues, health screening, and health-related interests of women with disabilities. And so we submitted and received a grant from the Health Promotion for Women with Disabilities, a 5-year grant from Bristol Myers Squibb Foundation. The first grant that went in, I will never forget the words from the person at the foundation, looked at it, got back to me and said, you need more money. I mean, how often do you hear that? I haven't heard it since. So some of the things that we did, and this was certainly not a single person effort, we had a group of faculty members who were looking at various pieces, and based on our research and the research of others, we found that many health issues for women with disabilities are the same as women without disabilities. But there are some specific issues related to their health. They are at risk for secondary conditions, obesity, pressure ulcers, diabetes, etc., because they have a smaller margin of health, or a smaller margin of safety, if you will. So something that would not, that most other people would be able to recover from quickly. If somebody has a relatively high spinal cord injury, they get a respiratory infection, they can get into trouble a whole lot quicker, and with more severe outcomes. Some health issues in women with disabilities are more likely to be ignored than in women without disabilities. Sexual health, sexual practices, sexual abuse, STDs, conception, pregnancy, and childbearing. Healthcare providers often don't ask, first of all, because they assume that women with disabilities are sexually inactive. Women with disabilities will tell you otherwise. There is also a higher risk for violence among women and men with disabilities. Those with developmental disabilities, mental disabilities, blind or deaf are at greatest risk. Some health issues have earlier onset. If somebody has a disability, and I'll talk about one specific example in just a second, and many people with disabilities report negative encounters with healthcare providers. Now, the consequences of these negative encounters is that women with disabilities, and I'm only focusing on women here for this reason, is that the Bristol-Myers Squibb Foundation project was focused on women specifically. You might say, well, why? Bristol-Myers Squibb makes products for women, and so they were interested in women as opposed to men. But we have broadened our focus not just on women, but men with disabilities as well. So these negative encounters often result in women with disabilities avoiding healthcare providers unless and until it is absolutely necessary, when they have no other choice. Some of the consequences of that are inadequate health care, including preventive screening, delay in treatment, lack of treatment. An example of that is women with disabilities who have breast cancer don't get the same options even presented to them. Healthcare providers make the decision without asking them. And it causes, as you can imagine, great consternation when they find out that perhaps they didn't have to have a total mastectomy, because that's not the standard of care today anyway. Delay in treatment or lack of treatment, and low level of participation in health promotion activities. Consequence of that, poor health status, isolation, and psychological issues. Some people say, well, you know, individuals with disabilities are depressed. They're not depressed because they have disabilities. They typically are depressed because how they're treated as individuals with disabilities, because they're ignored. So here's one example of earlier onset of age-related health conditions that occur in women with disabilities: low bone density and osteoporosis. In the Bristol-Myers Squibb Foundation project, we were doing health education for women with disabilities, and we thought, we need to be doing some data collection. And so one of the things that we did was to have bone density screening. This is not diagnostic testing, but bone density screening available for individuals with disabilities who came to the education program free of charge. So the purpose was basically to examine bone density and osteoporosis risk factors, because we always have to ask them a bunch of questions about that, in women with disabilities, and to examine their use of osteoporosis prevention strategies and previous bone density screening. So we did bone density screening. We administered a questionnaire on risks, risk reduction behaviors, medications, and previous screening that they might have had. This is a summary of the bone density screening results in 429 women with physical disabilities. The sort of greenish bar represents normal bone mineral density, yellow osteopenia, so they have low bone density but not severe enough to be labeled osteoporosis, and the blue is osteoporosis, using the World Health Organization classification of bone density. So you can see that just a slightly over a third had normal bone density, the rest did not. And many of them had osteoporosis, and many of them had, fewer of them, but still a lot, had osteopenia. And I want you to imprint this on your brain for about 30 seconds, because I'm going to show you another slide. This, by the way, I believe is still the largest series of women with disabilities and bone mineral density testing results. This is a study that was done by Cirrus and a crew of people, using the same method that we did in terms of bone density screening, over 200,000 women. Now, the difference in the sample here, as opposed to the previous slide, in the previous slide, as I said, the people had disabilities. The mean age was something around 48. The youngest was 20 in age, and I believe went up to 74, something like that. In this study, however, this group was comprised of all women 65 years of age and older considered postmenopausal. And so you can see the huge difference in the incidence of osteopenia and osteoporosis compared to the women with disabilities. So, summarizing that, women with disabilities have a higher incidence of low bone density and osteoporosis than expected, and certainly a higher incidence than people without disability. It is, however, largely ignored, and women are not being treated despite increased risk for falls and fractures. We did a couple of follow-up studies. We wanted to know, once women, got their results, what did they do with them? Told them what they should be doing is taking their results off to their healthcare provider so that their healthcare provider would know what to do relative to, any subsequent diagnostic testing and treatment. Some of the women reported back to us that their healthcare provider said to them, "We knew that. We knew you had osteoporosis." Well, the women didn't. And then they were told, "Don't worry about it." And my question is, okay, they're not worrying about it, obviously. They're telling you not to worry about it, so who's going to worry about it? Me. I'm going to worry about it. So there is a higher incidence, as I mentioned before, in bone density and osteoporosis, and at younger ages, because of the severity of a disability. Lack of attention, is huge. But this, however, is not limited to people with disabilities. It is also ignored in people who are not only healthy otherwise, but may even be hospitalized. A white woman hospitalized for a hip fracture, the chances are that that's anything other than osteoporosis is about 1%. So it's probably due to osteoporosis. Women leave the hospital after a hip fracture, repair of a hip fracture, without anybody talking to them about osteoporosis and what they can and need to do relative to prevention of injuries or treatment. Huge issue in this country. Little or no follow-up of osteoporosis risk by healthcare providers. We also administered something called a score, which is, it's a terrible name because you talk about the score on the score. But the score is actually the name of the index. And we administered this. It failed to predict low bone density in women with disabilities because it was not ever tested on people with disabilities, and it was never tested on women with disabilities because women with disabilities are excluded from studies. So what we need is an index for women with disabilities in order to identify who is at risk for osteoporosis. So this index was not a whole lot better than chance, so we still need a lot of work done in that area. Now, some of the questions that came to my mind, in this work on disability was, what is being taught in nursing education about disability? 60 million of us out there. And what is the quality of nursing care received by people with disabilities? And so those questions basically led to some subsequent studies. In terms of what is being taught in nursing education, we conducted 2 studies, one of which was a study of the integration of disability-related content in undergraduate nursing curricula, and a study of integration of disability content in nurse practitioner programs. So we conducted these 2 studies, stratified random sample of undergraduate faculty members, a national sample of nurse practitioner programs. These were 2 separate studies. Surveys were developed, importantly, with input from people with disabilities, and then analyzed. Briefly, and in terms of summary of the findings, some people said that they taught disability or taught about disability. Their responses to the other questions suggested they probably weren't. But we reported that they said they did. One of the things that was fascinating to me, because one of the questions we asked was, what resources do you use to teach students about disability? People said textbooks. Now, as the author of a medical surgical nursing textbook, I knew what was in the competition. You have to. So I knew what was in the competition, at least in terms of med-surg nursing textbooks. And I knew that there was virtually nothing there. So one of the things that we did is a subsequent study I'm going to tell you about in just one second. But 94% that said that they used textbooks, and we'll take a look at that in just one second. The topics they reported discussing were at the extremes of age. They talked about disability in terms of the frail elderly. They talked about disability, or at least they said they did, disability in children. They reported that more content would have to, or other more important content would have to be eliminated or deleted in order to address disability, which, after all, is not very important. And then my response to that is 60 million people out there. How can it not be important? Because that's a bigger number than many of the other primary health issues that people die of. 60 million people is a lot. Students are not tested on disability. It's not on NCLEX. It's not on certifying exams for nurse practitioner students. Therefore, we don't teach it. That's disturbing. That's very disturbing. Some faculty, I sort of considered this a positive, some faculty admitted that they never thought about it before until they completed the survey and said, gee, I don't know. We ought to look into this, which to my way of thinking is a good thing. So because of this textbook thing, 94% of the people saying that they were using nursing textbooks, we decided we wanted to examine what's in those textbooks. I don't know how many of you are familiar with the work of Betty Farrell, but she did something similar to end-of-life care, and we followed her model in terms of examining coverage of disability-related content in textbooks used in nursing curricula. You will see on the subsequent 2 slides, this has got to be the most tedious study on the face of the earth. Somebody suggested recently that since a little bit of time has gone by, I should repeat it. And I said, I'll find someone else who would like to do it. I'm not repeating this, and you'll see why in a second. So what we did was to compare the extent of coverage of disability-related content by categories of content and categories of textbooks used in nursing curricula. This is the first of 2 slides showing all the steps. So you can see that this is very tedious. Very, 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 very tedious. Any takers? Anybody want to replicate this? What we ended up with was ratings by specific categories, which I'll show you in just 1 second, and identification of the strengths and weaknesses of individual textbooks and categories of textbooks. Let me also add that for obvious reasons, we could not review the textbook of medical surgical nursing. That textbook does have a chapter that includes disability, and disability is integrated within the systems in the book. But we could obviously not do it just because of the conflict of interest. So this is basically what we ended up doing. We had 33 undergraduate textbooks. There are many more textbooks than that around. These are the books, however, that had the largest market share, with the exception of the textbook of medical surgical nursing. We used the AJN Book of the Year list, as well as, I don't think they do Brandon Hill list anymore, they used to. Identify what are the textbooks that faculty ought to have in their back pocket in terms of teaching. So, and this is the breakdown of the 33 textbooks. These are some of the results. The range of possible scores was 0 to 448, because the assessment tool that we used had 224 items. They were scored from 0 meant no content, 1 meant some effort, and 2 meant they did a pretty good job. So if you take those and multiply them 224 by 2, then the maximum is 448. The mean score was 7.4. It's very close to little content. Very, very close to very little content. We looked at, I'm absolutely blocking on what the means refer to here. But at any rate, the community health textbooks, interestingly enough, some of the strongest books were in community health. Some of the worst books were in community health. The assessment books, and these were not just nursing books, these are books that are used in nursing programs related to nursing assessment, so the Bates and all the rest of those things, is a perfect opportunity to talk about assessment of people with disabilities, and it was virtually absent. It simply wasn't there. So in summary of this particular slide, all categories of textbooks, because we couldn't review mine, failed to address the topic of health issues of people with disabilities. The depth and scope was extremely spotty and uneven within categories. And again, the community health was the best example of that. Disability was largely limited to age-related disabilities. There was stereotyping in the books specifically related to the elderly. Those of you in gerontology, I'm sure, will love to hear that. And people with disabilities. People with pre-existing disabilities related to any cause were rarely, if ever, discussed. Simply was not there. Modifications needed to provide nursing care, including patient teaching, was infrequently discussed. An example of that, the most common cause of blindness in the United States is what? Diabetes. It's diabetes. If you go to the Diabetes Association website and you look for education materials for people with low vision, there is no such thing. Perfect place, you know, to accommodate people with a vision issue, which would help them in the long run. It may save the vision they have if they knew about how to manage their disease better because they had something they could read. It simply isn't there. Abuse of people with disabilities was missing from the discussion in almost all books and almost all categories of books. We're not done here. So we were also interested in what happens in the hospital, given that people are coming into nursing programs and leaving programs without much attention to the topic of disability. What does this say to us, or what happens in terms of people once they're hospitalized? In terms of background, most studies on healthcare of people with disabilities focus on the outpatient area, and they typically refer to medical care only. People with disabilities have strong negative reactions to the idea of hospitalization because of the fear that nurses lack knowledge about their healthcare needs. I worked for a while with the director of the New Jersey Division on Disability, and he told me that he used to get calls from people who say, I'm going to have to go to the hospital. You've got to find an aide for me to go with me. And their fear was that when they went into the hospital, the nursing staff would not know how to care for them. Bad commentary. People report, and certainly have experienced, negative, sometimes even catastrophic outcomes during hospitalization. So no wonder they were frightened. So the purpose of this study was to explore the experiences of people with disabilities and their interactions and encounters with nursing staff and their perceptions about the care they received. So this was a qualitative study using focus groups of people with disabilities residing in the curriculum. So we had 35 people in a total of, I believe it was 6 focus groups with diverse disabilities, ranging from mild to severe. Several of them had mild intellectual disabilities. One of them had disability that was so severe that the only way he could communicate was with a communication board. So people had to be able to communicate one way or the other, able to participate in a focus group, and they had to report that they had previously interacted with nurses during hospitalization. We asked them about positive as well as negative. We asked them about concerns or fears related to being hospitalized and anything that they wanted to add about what makes them feel safe and well cared for by nurses in the hospitals. There are 4 major categories that we identified in terms of themes. I'm not going to go through these in detail. I'm just going to highlight a couple of them. Poor communication was number 1. This comes up in every single study that addresses disability, the communication. This is not just with nurses. This is with physicians. This is with other healthcare providers. One of the women in this study very sincerely said, nurses need to learn about communication. And of course, as a nurse educator, I know how much time is spent in most nursing education programs to teach students about communicating with people, related to healthcare. We spend a lot of time doing that. And for all intents and purposes, as far as this woman was concerned, the students have never, or the nurses have never been taught how to communicate with people communicate, period, and then add to that, communicate with people with disabilities. People had to explain and re-explain their disability. Disabilities in terms of compromised care. Disability was not taken into account during care related to inadequate knowledge. The care was not individualized. They described the nursing staff as non-caring, no compassion, no understanding, no patience, and no respect towards people with disabilities. Kind of scary. Negative attitudes. They saw themselves being considered low priority, marginalized, and they felt that they were viewed by the nursing staff as a burden. felt feared. Some people asked them if they could, some of the staff asked them if their disability could be caught. They reported being ignored and on occasion abused by the healthcare team. They reported that they were treated as children. This is universal. I hear this over and over and over and over and over again. It's as though when your legs go, your brain goes. And everybody, when I talk to people with disabilities, they nod because they've all been there because that's how they've been treated. Fears about hospitalization, and most of us in this room know enough to say, well, we all fear being hospitalized. If you're going to be hospitalized, you want to get in, you want to get out as soon as possible. That's even more of an issue for people with disabilities. Their great fear is leaving in worse condition than they came in with. They also have a fear of lack of control, fear being left without their assistive devices, and these are all based on their previous experiences. Their devices are taken away from them or put way over there, and they can't reach them. And it's like somebody took their legs away from them. We published this in the American Journal of Nursing for a particular reason, one of which was we wanted to reach as large an audience as possible. And I will say that after the article was published in the American Journal of Nursing, there were about 3 or 4 letters that were published. One of the things that we as professionals need to do is to write letters to the editor, about particular articles. They rarely, if ever, appear. They do on occasion, but we need to do more and more of that. So a number of people did write in. This is the only time I believe that I've ever had that happen. That people wrote in and said, yes, that happens to me, or that happens to my friend, or whatever the case may be. So in terms of summary, the views of people with disabilities about nursing care, they're no different than those of people seeking primary and other health care from physicians. It's not what it should be. There is definitely room for improvement in nursing care of people with disabilities during hospitalization. We need to improve education and training of nursing students and nurses in practice. And we need to take to heart the ICN's explanation about what nursing and nursing education needs to do relative to the topic of disability. Ancillary staff, however, also are in need of training because often those are the folks who give the hands-on care, and that's very important. One of the things we had to do in the course of this is to keep bringing people back to, we're talking about the nursing staff here, because they would go down the road of talking about their healthcare provider. No, we want to hear about the nursing staff. And they did that. And then at the tail end of this whole thing, they said, oh, but the nurses were great. So we said, wait a minute. You just said, you spent 30, 40, 50 minutes telling me about all these negative experiences. How come you're now saying the nurses were great? So it became very clear that they tended, before they were lumping nursing with the physicians, now they're lumping nursing with the non-professional staff together in their descriptions. But that's one of the things that suggests very strongly to me that it's the rest of the staff needs training as well. There have been reports and agencies calling for improved knowledge, skills, and attitudes of healthcare providers about caring for patients with disabilities and to improve their health care. These are some of these organizations that have done this. The Surgeon General reports, at least 2, the Institute of Medicine, the National Council on Disability Report, the World Health Organization, the International Council of Nursing position paper that I shared with you, and the Affordable Care Act, all called for some attention to this issue. Alas, that section of the Affordable Care Act was not funded. Despite these calls, nursing as a discipline has largely been unresponsive to these issues. To that end, I have spent 7 years getting in the face of people from the National League for Nursing. And I am very delighted to say that they have decided that we are right, that the NLN needs to and will step up to the plate and address this issue as an important issue of nursing concern. But it took 7 years for that to happen. So that's the latter part of this. The first part, one of the other things that we're doing right now is integrating standardized patients with disabilities in the undergraduate program. We've also already done this in the nurse practitioner program, and we are examining such things as students' perceptions, students' attitudes toward people with disabilities before and after. And we have a focus group study which is I think, going to be published, well, it's going to be accepted, I don't know when it's going to be published, in Nursing Education Perspectives about the experience of the standardized patients themselves, who are invaluable in terms of educating nurses about disability. They love doing this, the students love having them, and it's made a world of difference. And I just mentioned the NLN. For those of you who are familiar with the ACES program from the National League for Nursing, it started out as just ACES, then it became ACE/S for seniors, and there will be a new one, and it will be ACE/disability. And we will be intimately involved with the NLN in making that happen, so I'm thrilled to death by that. One of the other things that we're doing is secondary data analysis of NHIS data related to health issues of people with disabilities. I'm also involved in 2 projects that are NIH funded, addressing unmet needs of women with physical disabilities, and this just gives you an example of some of the mixed methods that we're using. One of the things that I did not mention, a lot of this has to do with women's health. I am a dyed-in-the-wool med-surg nurse. And you're probably saying, but how are you getting into pregnancy and all this kind of stuff? What I was doing is basically following where the research took me. Okay, and that's where it took me. I am somebody who still has to describe pregnancy in trimesters. If somebody told me the weeks, I cannot get my head around that. That's how much of a non-OB women's health person I am. I still think in the traditional way. So, last slide, almost. A summary of all this. What I have presented to you has not been planned out ahead of time, because as I say, I've been following where the research took me. And the research findings have been based on the findings of our previous efforts, as well as those of other people. The variables have ranged from physiologic measures, such as maximal inspiratory pressures, bone density, etc., psychological issues, views and perceptions of people with disabilities about their experiences. The methods have been mixed from pure quantitative to pure qualitative to mixed methods and psychometric analyses. The data collection approaches have included surveys, physiologic measures, the ones that I just talked about, qualitative interviews, focus groups, and existing databases. Funding sources have been sort of all over the map: NIH, HRSA, MS Society, Bristol-Myers Squibb, ASPE, NLN, and others. Publications have ranged from medical, nursing, and interdisciplinary research and clinical goals. Despite all that, or journals rather, despite all that, my goal has been the same, and that is to increase the health and well-being of people with disabilities. Think about this. Disability is a universal experience that affects nearly everyone without exception in some time in their lives. And so we need, I think, as healthcare professionals, educators in health profession schools, to step up to the plate to make sure that our students graduate from whatever level with an ability to provide quality, sensitive care to people with disabilities going forward, and that's going to include us. And if that's the only reason, I'll buy it if that's the only reason, so that somebody's there to take care of us when we get to that point. But we have to do something. And I'm hoping that our foray into working with the National League for Nursing will make a huge difference. I'm counting on it. End of slides.
In appreciation of your participation in our research day and your valuable work, we honor you with our 2015 Spirit of Nursing Award. Thank you so much.
I had the good fortune of actually meeting Bob when he was at Teachers College at Columbia University, and this suggests the kind of work he does. We were grappling with a problem of how do you measure physical activity and cardiovascular risk in children ages 2 to 4. And that's still probably an ongoing problem. And then I had, again, I had good fortune of being invited down to Medical College of Georgia, where Bob had subsequently gone after Columbia, and he was the founding director of the Georgia Center for the Study of Obesity and Related Disorders. And then trying to introduce Bob, I was thinking of trying to demonstrate how well he fits, actually, at UMass Boston. And the first thing I thought of is something that's not on his resume, and I hope he feels okay with me telling you this. Many of our students and even our faculty, is Phil Trobit here, work their way through school and work their way through UMass Boston as taxi cab drivers. And Bob has the distinction of being a taxi cab driver in New York City. And so I think I'm safe in saying that even compared to Boston, being a taxi cab driver in New York City is quite an accomplishment. And then I started looking at his resume, and he has like over 200 publications, and I wasn't going to list all of them, thank God. But I thought I could capture some of the things he does, and also how it relates to UMass Boston by mentioning studies he's done. And being that it's just about finals week, and we've made it through the semester, and I think students are thinking along these same lines, his very first publication was titled, "The Effect of an Increase in Physical Fitness Upon the Performance of Mental Tasks Following Physical and Mental Stress." So I thought that would relate to our mood as we move into finals week. Now, a decade later, he published on the determinants of cardiorespiratory endurance in college women. And then moving along, fitting in with another decade later, fitting in with the global approach of the University of Massachusetts, Boston. He has a publication on obesity prevention and exercise in countries undergoing technological development. I thought I'd find something related to nursing, and a decade after that, he has published a study called "Does Tourniquet Use During Anterior Cruciate Ligament Surgery Interfere with Post-Surgical Recovery of Function?" And then we like to think of ourselves as being interested in nutrition as well as physical activity in our department. And I found a publication then a decade later on plasma leptin concentrations in obese children, changes during 4-month periods with and without physical training. And then finally, some more recent work that he's done includes the relations of visceral adiposity to cardiovascular disease risk factors in black and white teens. And then the final one I thought I would mention is the role of nutrient partitioning and stem cell differentiation in pediatric obesity, a new theory. So you can see Bob's been involved in cardiovascular health and issues related to cardiovascular health over a long career, and how well his interests fit in with our students, our faculty, both in nursing and in exercise and health sciences, relating to the University of Massachusetts generally. And so I bring you Bob Gutin.
Well, first I want to thank Ron for reminding me of all those projects, and I'll thank everyone else for not asking me what was in them all those years ago. Well, with respect to the title, how can youths develop lean and healthy bodies, I thought I would stop there, and then I thought, well, there's this principle in teaching. First, tell them what you're going to tell them, then tell them, and then tell them what you told them. So I thought I would leap ahead and give you this advanced message, the importance of vigorous physical activity. And I emphasize the word vigorous because it has important implications for what kinds of interventions we might employ to prevent obesity and promote lean body composition. I might also comment on my name. A lot of people ask me, well, don't you like the name Bernard? Where did this Bob come from? And I like to mention that first day of school, when I was about 5, I guess, my mother said, well, Bobby, what did you learn in school today? And I said, I learned my name was Bernard. So I think Bernard's a fine name, but my family and my close friends still call me Bob. So when I met Ron, we were working on a multi-site, well, all the grants were somewhat independent of each other, but we came together, as he mentioned, And we were asking this general question: do adult diseases like heart disease start in childhood? Which was kind of a new idea at the time. And so we were in Manhattan, so we studied mainly Hispanic 5 to 6-year-olds. We measured fitness on a treadmill, fatness with skin folds, and we found that just as with adults, those who were low in fitness and high in fatness had higher blood pressure. And when we followed them for 2 years, we saw that the changes went along in the same way. Those who became fatter had more of an increase in blood pressure. So it implied that we really should be thinking about the early origins of these diseases. When I took the position at Medical College of Georgia, it was at the Georgia Prevention Institute, which was part of the Department of Pediatrics. So our focus was on continuing that line of investigation. And the overall model is shown here. And we went on to look at first physical activity and diet as they influence body composition and fitness, and then how they in turn influence various of the cardiometabolic biomarkers. And we don't have time to go into this whole model, including the predisposing factors like genetics, race, sex, and so on. And we're still publishing from some of the data that we had back then, because they, we saved a lot of the blood samples and so on. And as some of the new people at Georgia get into the picture, they come up with new methods of measuring various risk factors for heart disease and overall mortality. And we find that a lot of them are influenced in the children the same way that they are in adults. So we're going to focus on physical activity and body composition. And I'll say a little bit about diet, not much. I won't say much about aerobic fitness because actually the changes in body composition go along with the changes in fitness to a large degree. So how do we improve our understanding of body composition? Well, first, we don't always do these things in the same order in which it's convenient to present them later on. But in general, descriptive epidemiology is thought to come first, where we observe linkages between various variables, and then we generate hypotheses that could be tested with various other models. So, for example, pediatric obesity increased tremendously in the 20th century, and what could be the cause? So you see over the decades, last 4 decades or so, quite a substantial increase, and this is a great concern for the society, of course. So here's a hypothesis. I started working on this problem just about that time. Is it conceivable that one person could have such a deleterious effect? Well, I don't know. I don't know how that would be, but we could test it. So you might think that this is a service beyond the call of duty for me to actually retire just so I could test this crazy hypothesis. But I did, and the prediction would be that the prevalence should go down, and it did not. We're still seeing a slight increase, maybe a stabilization. So that's not such a good hypothesis. And it has a very limited biologic plausibility. So we're going to look somewhere else. So another thing we typically do is look for biologic plausibility. We say we have a relationship. What could be the biologic mechanism showing that link? And it can be done with animal studies and in vitro studies and so on. And then ultimately we want to test the hypotheses with human experiments. So that's the overall pattern. So let's look back and say, what's the logic of child obesity prevention? Well, first of all, we should remember that most kids are not fat. So if we see a prevalence of even, depending on how you define it, if you just look at obesity, maybe 15, 17%, that means most kids are not fat. And so what happens? Why is it that most adults are? So something must be happening in those years. So that's really the question we want to ask. Now, if we can determine why some become leaner or fatter than others, then we can focus our intervention efforts on those causes and presumably have a beneficial effect for the next generation. And I want to emphasize the word growing. You notice that in there. That it's very common to think of how these processes work in adults and therefore make generalizations as to what they might be in children. And in many cases that works, but in some cases it doesn't. Because children are growing, and something about the biologic processes of growth are very important when it comes to development of body composition compartments. So, for example, an adult can lose weight by going on a diet. It's the best way. With exercise, moderate exercise actually, becoming an ancillary supportive aspect of behavior. But dieting is really important to lose weight. But with kids that are growing, you don't want them to lose weight. That's not the relevant question. So this leads us to which aspects of diet and physical activity might be the main causes, and then we can test hypotheses about whether altering them in childhood can have a beneficial effect. And another important aspect is how you measure the outcomes. Which indices of fatness or leanness do you use? Body weight works pretty well for adults. It works pretty well for children also if you just want to draw generalizations about prevalence. So the body mass index is useful, but it's not useful for children who are increasing in weight. So really the question is, why do some kids put on more fat and other kids put on more lean? It's a different question, and it leads you to a different type of design for the research. So here's an issue. You see this little chubby kid. You don't have to measure him with sophisticated measurements to know that. And he says, can Johnny come out and eat? So the implication is clear that there must be something about eating too much that is causing his fatness. So here's the model. It's very common that everyone knows that people and kids who get fat, or I should say fatter than other kids, because that's always the comparison you have to make, they eat too much. And so it's shown very clearly. When we say diet, in this case, we mean energy intake. And we think that kids who eat more than their age mates will have a positive energy balance. Or if they do less exercise that causes lower energy expenditure, they'll have a positive energy balance. They'll have the deposition of energy into the body converted to mass, and this is the typical model. Anybody want to leap up and say, of course? First time I mentioned this to people at Duke, I live in Raleigh near Duke, and I was talking to the cardiology people, and one of the outstanding researchers in this field said, of course that's the way it is. It's the law of thermodynamics. And I realized I was in trouble because he thought I was going to repeal the law of thermodynamics. And I had to assure him I wasn't going to, but that this model is somewhat useful, but it's not the best model. And one reason is that, as I mentioned, body mass index or body weight is not really a good way to find out about how kids are developing new tissue. And that's because the numerator includes fat and lean mass. So fat mass is unhealthy, but lean mass is healthy. So the numerator of the body mass index is has a positive and a negative component to it. Especially, this is important when you're thinking about the role of exercise, because exercise, especially vigorous exercise and high impact, I want to emphasize the word impact, exercise leads to an increase in lean mass and a decrease in fat mass. So it influences the numerator in opposing ways, when really what we want to know is about the two separate components. And fortunately, many recent studies have been using good methods of body composition. So that's good. So it's possible now to look at efficacy studies that have measured body composition in good ways. And I routinely do not look at studies that involve weight. It's not useful if you want to know about the influence of exercise, or diet for that matter. So when I got to Georgia, this was 1991, we had typically at Columbia, we had an underwater weighing tank. Anybody ever go in an underwater weighing tank to get body composition measured? Oh, we have a few here. Well, that's what we typically did, but DEXA, or dual energy X-ray absorptiometry, had just recently been invented, and I believe we were the first ones to use it to measure body composition in healthy kids. And actually, I flew up to Boston here to the Hologic company one day. I'm probably one of the only people who's been measured on 3 different body composition X-ray techniques or photon absorptiometry techniques in one day. I flew up to Columbia, and they had 2 there, and then I flew up here the same day, and I was measured here. And I decided Hologic was the best. So the idea is that underneath the table, there's in this case, an X-ray source, and then the photons come up through the body, and then there's a scanner that goes over the top. Whoops. And then you get an image like this, and it tells about the density of tissues. And so you can get a 3-compartment model. You can get bone mineral content, from which you can derive density, or actually it's done the other way around, technically speaking. But there are 3 contents that you can get, 3 compartments: bone mineral, fat-free soft tissue, which is mainly muscle, and then fat mass. And typically we integrate these by looking at the percentage of the body made up of fat. We also were interested in visceral fat, which was just coming into the picture as especially deleterious to health. So we collaborated with people in radiology, and we used MRI at odd times during the day and the evening when they weren't using it for clinical studies. And we evolved a way of measuring 5 different cuts across the abdominal region. And here's the definitive slide, so to speak. It's a cross-section across the abdominal region. And you can see that this is a subcutaneous fat. And you can see these 2 children have about the same amount of subcutaneous fat. But when you look at the visceral, that is the intra-abdominal fat, you can see this child does not have too much. And here, the white material is all visceral fat. And we found that even in children, even though they don't have too much, it's mainly an adult problem, it still distinguishes kids with worse lipid profiles or insulin resistance. And then we measured aerobic fitness with treadmill tests, typically. And I want to emphasize that we also indicate physical fitness by using heart rate response to submaximal effort, which is really a good way to do it, because with obese kids especially, they tend not to want to push themselves to maximal effort. So you're getting a poor measure sometimes. So using heart rate, so you see the heart rate goes up much more rapidly in a child with low fitness at a given locomotion speed and it goes up much slower in a child with high fitness. So this came up in the last day, interacting with some of the people last night and this morning, actually, about the difference between theory and research, and then the public health implications. And it is important to emphasize that these are different aspects of the research enterprise. You must have theory, and the reason is that when you want to draw an implication for a public health measure, you do it from the theory. You almost never go directly from a research finding to an intervention, at least if it's a basic research finding, like an efficacy study, and I'll show you some of those. So the idea is that if youths become fat because they eat too much, then we derive a research hypothesis, which is if we measure a wide variety of kids, we should find that the fatter kids eat more than the leaner kids, right? Isn't that, everybody agree with that? Is there anybody who wants to take issue with that? And then if that's true, this arrow has 2 points, it goes back up to the theory, it supports it, and then we say, well, then we ought to teach kids to eat less as they're growing up, right? And they'll be less likely to get fat. So you see that relationship between the theory going down to the research and bouncing back up to the theory, and then the intervention. Now, Karl Popper was a very famous philosopher of science, and he contributed this concept that the way you know whether the theory is correct or not is by trying to falsify it. So you have to formulate your research in a way that allows you to contradict what you really believe to be true. This takes a little mental gymnastics for some people. And they don't want to do that because they'd like to support their hypothesis, right? Doesn't everyone? And yet, if the design of the study does not permit you to falsify your hypothesis, it's an improper design. It's not a good design. So that's an important lesson. Because it's very hard to find studies showing that fatter kids eat more than leaner kids. Very hard. I used to just put a big question mark there. Where are all the studies showing this if everyone knows that's true? And even more surprisingly, there have been a number of recent studies showing that fatter kids tend to eat less than leaner kids, including right up to the present time with a large European study that was done. And this paper by Cuenca Garcia and others, many others, including me, I advised them about this study. This was an interesting thing to do because I knew the data they had, and I knew that they had collected, because I did a Fulbright in Spain, so I knew that they had collected dietary data, but they hadn't published any. They had a lot of other stuff, including exercise data published. And I said, how come? And so one of the fellows said, well, they haven't figured out what to say about them yet. I said, what you mean by that is they found that the fatter kids ate less than the leaner kids. He said, yes, that's what we found. So I said, well, I think you should publish it. And it turns out that it was a pretty good study, and I think it just came out. Here are some of the data, actually. Here's percent body fat on the vertical axis. I'm sorry, this is energy intake. Here's percent body fat. So here we have, I wish it would stop doing that. I'm not even making it happen. I don't know my own strength. Well, here you have the 0.25% body fat. Here are the leanest kids, and they ate the most. And here are the fattest kids. Right? This is energy intake on the vertical axis. And in order to try to take away the possibility that the fatter kids were underreporting which is a common criticism of all dietary studies, including with children, but it seems to be less likely with children. The results were unchanged after they eliminated from the analyses the obese subjects. Another recent paper, which is kind of interesting, what came from the TAG study, the Trial of Adolescent Activity in Girls. And they followed them from the 8th to the 12th grade. They measured diet with a 7-day diary and percent body fat. And they found the girls who increased the percentage of caloric intake from snacks and desserts were the ones who tended to reduce their percent body fat. Do I need to say that again? Should I let you read that and digest it for a minute? Because it's another one of those studies where the people scratch their heads. And if there hadn't been some studies mentioned, like the others I mentioned, these people might not have published those data. That's funny. I was taking a walk with the editor of the International Journal of Obesity, and I was explaining some of these data, and he said, "That's funny." He said, "Those are the two most exciting words in science." So I said, "Oh, good, I'm going to use that line from now on." Well, then what about diet composition? Well, there's some evidence that diet composition makes a difference, but it's very shaky at this point. In rodents, it's been shown that diets high in fat and sugar decrease accumulation of bone mineral. Bone mineral is a good thing to study, and I know some people last night were discussing with me studies on bone mineral, because DEXA gives you pretty accurate measurements of bone mineral, and it gives you an insight into the lean mass development. So you'll see that I'm tending to go away from the idea of prevention of obesity and promoting the idea of promotion of lean mass as being a better way to think about how to help kids develop healthy bodies. And then been in vitro studies that show that when they have high concentrations of glucose and lipid, it inhibits differentiation of stem cells into bone, and it directs them toward becoming fat cells. So the early development of these different types of tissues seems to be influenced by diet composition, that's not a surprise, of course. But keep in mind, that's diet composition. That's the percentage of total calories that is comprised of these different types of foods. And the epidemiologic and experimental studies in humans have been unsuccessful in really showing this in a consistent way. So that's a good area to investigate if we have any people interested in nutrition and body composition. That would be a good area. Of course, we need to be aware that measurements of diet are very imprecise. In fact, a whole group of very eminent obesity researchers recently came out with a paper saying, I think it was an editorial, that we should stop measuring diet. It's just not possible to get good measures. And fatty use may underreport. But this is the key, to my mind. It is unscientific to measure a variable at the beginning of a study and then run away from the data when they falsify your hypothesis. And that's what I believe is very typical for people in this field. I believe that those people who said we should stop measuring diet were collecting data that turned out to be contrary to what they knew to be true. Knew in quotation marks. And they were running away from the data. Now, if you think diet is a poor thing to measure, then don't measure it. But if you measure it, you are required to report the results. It's unscientific, it's un-American. I went to the JFK library yesterday, so I'm steeped in American exceptionalism. So what do we say if we believe the data rather than running away from the data and rather than blaming the subjects. Well, Benjamin Franklin said it in a very good way. There is nothing so horrible in nature as to see a beautiful theory murdered by an ugly gang of facts. Well, what about the other side of the equation? There must be something going on if fatter kids are actually eating similar amounts or even eating less than leaner kids. So with physical activity, the measurement is better, a lot better, and if we use accelerometry, it's much better. And many studies, I won't try to list them, but it's a very clear-cut finding that higher amounts of moderate to vigorous physical activity are associated with less adiposity, however you measure it. But one interesting thing that's emerged in recent years is when moderate and vigorous physical activity are examined separately, it turns out that it's the vigorous physical activity that is really explaining the variance in the fatness. Now, this is funny because, especially with accelerometry, kids do about 5 minutes on average per day of vigorous physical activity and about 40 minutes of moderate. So how could just a small amount of activity like that have such a big impact? This is one of the big puzzles, I think. And I'll try to explain what I think is an explanation that needs to be tested before we'll accept it as a good explanation. And here's some data from one of our epidemiologic descriptive studies where we have percent body fat on the vertical axis. We have here the amount of vigorous physical activity per day. Moderate did not explain any of the variance in percent body fat. Vigorous activity did. So this small amount, of course, that's on average. There's some kids who do quite a bit of it. So here you see the group that did none in 7 days of monitoring 0 physical activity, vigorous physical activity. That is a couch potato. And then we have, and these are adolescents, so where are they? I mean, when we look around the playgrounds or whatever, we see everybody, all the kids are running around, but they're at home watching TV or using a computer, I guess. And here's people who do 0 to 1 hour, and here's 1 or more hours per day, and you can see their energy intake, 1,700, 1,900, almost 2,200. So here's that same phenomenon. A lot more vigorous physical activity, they eat more, and they're leaner. So descriptive epidemiology seems to be very consistent in this regard. Whenever it's measured, vigorous activity is effective, or I shouldn't say that word, I should say is correlated with leanness, and moderate is not. Moderate would be walking, vigorous would be running. That's to give you an idea. Now, since I do a lot of dancing, I do a lot of international folk dancing, I always like to mention dancing is especially valuable, also for your cognitive function, which I studied many years ago. So how would we explain this? Here's some way we have to try to come up with a theory that includes a biologic explanation. How about stem cell differentiation? Well, when kids are growing, or even adults, stem cells develop into any fully mature cells. This is illustrated here that stem cells, and we're talking mainly about mesenchymal stem cells. These are stem cells in the bone marrow. If there's an injury, well, first of all, you can see that they can become any kind of cell. Here's an adipocyte, a neuron, a myocyte would be a muscle cell. So an osteocyte would be a bone cell. And they assist in repair of injury. This is the way I think they originally, and even to now, are being studied extensively. So you have an injury, some sort of a stimulation is provided to the bone marrow, the stem cells are mobilized, they're carried around into the blood cells, they go to the site of injury, and if you had a cut or something like that, it repairs the injury. Or if you have a broken bone, it repairs the injury. The people who discovered the relationship to obesity were biomedical engineers who were studying bone mass. They were studying repair of bone. And they found some interesting things. They found that the differentiation is competitive. Especially, they were surprised to find, I think, that when something was done to encourage the development of bone cells, the animals became leaner, or grew to become leaner animals. Well, what does that have to do with fat? I mean, it's bone and fat. They're two different parts of the body, right? They don't relate to each other. Aha. But they do. Because stem cell differentiation into different mature cells is a linked process. The same processes, and we don't know what they are yet. As we stand here, there were people working on this, biochemists and engineers and so on. The ones that become fat cells do not become lean cells and vice versa. And now, what effect does that have? Well, lean cells that are developing need nutrients. They need energy and they need nutrients to develop. And so they tend to pull the energy and nutrients into their cells. So in this model, instead of imagining that the fat in the diet is being pushed into the fat cells, it's a different way of looking at it. The energy is being pulled into the lean cells. And this is illustrated by a series of studies done by a group of as I said, engineers. They have a little vibrating platform. You imagine a mouse on a little vibrating platform. Stop and think. That's a good thing to think about for a while. Sounds like fun. And they found that this drove the stem cell differentiation toward muscle and bone rather than fat. So some bright person sitting in the lab must have said, all this time we've been studying bone, but we didn't ask what happened when the bone cells were being developed, what was not being developed. Ah, it must have been one of those great days in the laboratory. And they said, fat. And they found that these animals became lean, whereas the ones who were stimulated became lean. The ones who were not tended to become fat. They gave them a diet, by the way, that was designed to make them fat. So they got fat, except if they were on the vibrating platform. Then they became lean, even despite an obesity-generating diet. And there was no effect on energy intake. So it was not because of a higher metabolic rate that led. It wasn't energy intake that distinguished the groups. That's essentially it. And this is a very important thing. I have to figure out a way to give this more of an impact. The vibration was not effective in reversing the obesity that was already established. So if at the moment when the obesity-generating diet was given to the animals, they started getting the vibration regimen, they became lean, even though they were eating a diet that was designed to make them fat. But if they were made fat first with the diet and then given the vibration, it didn't work. That's important, isn't it? Because it tells you that once a person is fat as an adult, it's really hard to turn that around and make him lean. You may have had a good chance when he was a child. So it has a very important implication as to where we put our money, where we put our public health efforts. And this illustrates, they did an interesting pilot study with humans. They had osteopenic female adolescents, and they were on half of them were on a vibration platform. a lot bigger than the one they used for the mice. And here you can see the bone density. Oh, shoot. The bone density went up in the vibration group. Not much, you can hardly see it in the control group. The muscle area went up. Muscle and bone are very tightly linked, so it's not surprising they would both go up together. And here's the fat area went up in the group that was the control group. So in keeping with this, I'll just give you one other set of data from our epidemiologic study where we see the daily calcium intake. Now, we did find diet to be related to bone mass. Higher calcium intake, higher intake of energy, higher intake of dairy, vitamin D, but they were all related to each other, so you could pick any one along the horizontal axis, and you see there is a tendency for diet to have an impact, but you can see it's the vigorous physical activity has a much greater impact on bone mineral content. And bone mineral content, by the way, is a better measurement than bone mineral density for growing children, for anybody who's working on it. For adults, density is good, but for kids, they're developing bone not only to make them more dense, but also to increase the diameter. So it's the total bone mineral content that's important to measure. Now, there's a suggestion in here that maybe exercise is working the same way or through a similar mechanism as the vibration. We don't really know that. If you didn't figure that out as I was going along now, then you weren't thinking fast enough, because we don't know that they are working the same way. But there's some suggestion, and here's a study done by some of my colleagues at Georgia. The percent fat of the liver is here. Here's a control group. Here's a group that did vibration. And here's a and here's a group that was on a treadmill. So they both seem to have a similar effect, but there's no way to equate vibration with treadmill. You don't know what a dose response would be, so you can't really say. But it does look suggestive, doesn't it, that maybe they're working in similar ways. So maybe they work through similar mechanisms. And if so, we can develop a theory. Now, the theory may be wrong, may be right. The real question is, does it explain the data better than another theory? And so this is where I think maybe mechanical stimulation of vigorous exercise has a similar effect, because vigorous exercise, like running and dancing, impact, and it's been shown with bone mineral studies that high impact activity is more successful at increasing bone mass. So maybe it works through stem cell differentiation. You get more lean tissue than fat tissue, and here it is, they have to eat more, right? They're getting a lot of lean tissue. Lean tissue has a high metabolic rate compared to fat. The kids have to eat more. So this would explain the dietary data at the same time. And while you're thinking about it, I'm going to take a little drink. So far, we've been talking about observational studies, except the animal studies use experimental designs as well. And here's what we think is happening. So we have a relationship between vigorous physical activity and body composition. However, the direction of causality cannot be unequivocally shown with descriptive studies, because if you had a kid who, and genetic factors play an important part in obesity. There was a recent study that showed the effect of a physical training program in kids was determined by their genetic predisposition to be fat. So there's an interaction between genes and environment, in this case, physical training. So you get less of a beneficial effect in kids who are predisposed to be fat. So that may mean that, and also a kid who is predisposed to be fat, gets fat, is less likely to do vigorous physical activity. So it's hard to say how much causality we can attribute to this relationship, unless we use experimental designs where we can control the vigorous physical activity and see what happens. So what about, I'll just summarize some of these. Body composition is enhanced in both obese and non-obese kids by physical training. Whoop. And high impact and intensity exercise seems to have especially great effect on bone mass. That's been shown pretty clearly. But for total body composition, it's not so clear. So it still needs, there's plenty of work for the kids who, or faculty members who are working on this. But here's a suggestive result. Within the physical activity intervention groups, the kids who maintain a higher heart rate through the intervention, they tend to get better results in bone mass and in percent body fat. So that does suggest that intensity plays a role. And so we did a bunch of controlled trials at the Georgia Prevention Institute. And here's one thing that made it an efficacy study rather than, or made them efficacy studies. We have buses that go out to the schools and pick the kids up after school and bring them to our gym. So we have a research gym. I'm sure it's one of the largest in the world that's just used for research on kids. But we started with a small gym. Tom Baranowski had arranged to get this small gym, and we had machines that could be used the same way you would in an adult health club. And then we played all kinds of games that were modified to keep the heart rates up throughout. And the kids much preferred the games. And we got similar results in terms of the heart rate. So after that first study, we only used games. And so they may include things like jumping rope or modified soccer or basketballs. You notice that we don't have kids lined up with waiting their turn to shoot the basket. There are balls all over the place. It looks like chaos when you come into the gym. But every kid is wearing a heart rate monitor. Oh, here's one who's a comedian as well as a subject. She's choking herself with the band. And then we have a heart rate monitoring, which allows us every minute of every session to see what the heart rate is and keep track. So this is what makes it an efficacy study. We want to be sure that the kids are getting the dose of exercise that we're striving for them to get. And doing it by having them walk on a treadmill probably wouldn't work because they don't like that. It may work in adult studies. And the mean heart rates are over 160 beats per minute. We thought we would shoot for 140 beats per minute. And much to our surprise, even the obese kids have average heart rates over 160. Well, that's the average, so some kids are below and some kids are above, but we're shooting for a high level. And the kids who maintain a higher heart rates have the better results. Here's one of our studies. I was telling one of the fellows last night, he would appreciate this because it was a 4-month study. It was one of the early ones with that was fully funded by NIH. And so here's the randomization, and here's the group that had the physical training, and you can see after 4 months, they had a good result. The control group looks remarkably stable. And then after 4 months, we said, you know, we had it was a waiting list control, so we had that second group that was going to now get the intervention, and so we said, well, let's just measure everybody after another 4 months. Well, look what happened. It turns out to be one of the most interesting things, and we didn't plan it. The group that got the intervention at that point, well, they had a good effect, but look what happened to the other group. After 4 months and not being in our after-school program, they were continuing with all their other activities. they bounced right back up. It's interesting, isn't it? It means, it shows that from a scientific perspective, it's great to give an intervention, see what happens, and then withdraw the intervention and see the expected result. But it breaks your heart when you think about the kids getting fatter again. Here's a study we did where we were trying to look at the intensity by randomizing them into different intensities. Didn't work. The kids who were assigned to the higher intensity tended not to get to the level we were shooting for. Kids in the lower intensity tended to be a little bit higher. So we had a psychologist working with us, and he said the best way to describe some of these kids is that they have objective, what's that word? Obstructive objective behavior. I forget the exact terminology, but it's hard to control teenagers. The main thing we learned from this study is that we'll never do another study with teenagers. But we got some good results when we just looked at the kids who exercised versus those who didn't. And you can see that the percent body fat went up in the controls, went down substantially. This was an 8-month study, by the way. This was, I think, by far the longest study in the literature at the time. 8 months is a long time to control anybody. And then you can see the bone mass went up more in the exercise group, and the amount that they ate went up more than the other group. So this goes along with the epidemiologic finding. They're exercising, they're becoming leaner, and they're eating more. It makes sense, and when you think about it through this theory. Here's a recent study that some of my colleagues have continued with. The question was, if you get good results with a 40-minute period, what about half of that? Can you get good results with 20 minutes, which would fit more easily into a physical education class? And the answer is you do get results, but about half of what you get with a 40-minute period. So you can see a very nice dose response for percent body fat, for visceral adipose tissue, and we get similar results with visceral adipose tissue in all the studies that I mentioned. Fasting insulin shows the same trend. 40-minute group showed a very nice reduction in fasting insulin, which implies better insulin sensitivity. And they looked at bone, now that we're thinking about bone coming into the picture, they looked at bone formation markers and showed, again, a similar dose response where the kids who exercised the most had increases in osteocalcin, for example. Whoops. So we get to the dose of exercise. What improves body composition if you start with overweight kids, which most studies do because it's an obesity problem, right? So they think we have to start with obese kids. We did. Made sense to us. And we get large muscle activity is good, and the FIT principle, we get good results. And by the way, what I say about us is similar to what others have shown at the same time, subsequent to our work. A frequency of 3 to 5 days per week of actual exercise, not you have a program that is 3 days per week, and maybe they come 2 days per week, maybe 1 day per week. We offer the program every day, 5 days per week, a school day. The intensity we think should be vigorous, running rather than walking, or dancing rather than not dancing. Overweight youths can maintain high heart rates, that was a revelation to us. And about 40 minutes a session works well. Strength training is an open question. We think it works, but there was a study that just came out of the University of Pittsburgh just a month or two ago showing it had a beneficial effect on visceral fat, but not on total body fat. So it's still a good question for people who are looking for questions to pursue. Now, what about non-obese youths? Well, one of the strange things is that the same formula that works for obese kids seems not to work for kids who are not obese at the beginning. And this led some people to say that exercise alone is not an effective treatment. That even for kids, you need to have diet. But we said, well, that may be true, but maybe the doses that have been used have been insufficient. So I had a grant application, came back, it was not funded. And they said, what do you mean, 2 hours of exercise a day you're going to give these kids? Kids can't do 2 hours of exercise a day. To which my response was, how do you know? Because it hadn't been studied, so I said, okay, I'm going to change it to 90 minutes. And actually, I always intended for it to be around 90 minutes because when they come in, you still have to put the heart rate monitors on. It's after school, they have to give them a snack. And so we got funded, I'm happy to report. And we called it adiposity prevention by exercise. So we recruited black girls and then boys, 2 different studies, and they varied in fatness, and it was prevention. Now, fat kids in Georgia are the demographic group that tends to get the fattest. I'm sorry, black kids are the ones who become the fattest. And here, instead of bringing them into our gym, we went to them. And we did the measurements at our place, but we did the actual intervention at their place, and that made it more an effectiveness study to some degree. So 80 to 90 minutes per session, and it was a pretty high amount of exercise, much greater than had been previously used. And here's some of the girls, and they love the heart rate monitors. It's really interesting. Some time ago, I was involved in one of the studies, and the kids came running up, oh, look what my heart rate is, and then they would go running off and run around the gym like mad and run back, say, look what my heart rate is. So it's really a terrific intervention. It gives feedback to the students, it gives feedback to the teachers right then. So I advise you, if you're thinking about an intervention, use heart rate monitors. What are the results? Very good. Here's the change in percent body fat. You can see the experimental group and the control group. Bone mineral density, bone mineral content rather, went up more in the group that exercised. And by the way, it was a 10-month intervention, which is even longer than the previous ones that we used. And it went through the summer, by the way. That's an interesting thing. I'll come back to that. Because people started at different times. You had to do the testing and then incorporate them into the training. So you had testing going on for a month or two. So it went through the summers. And we did it with boys, and we got a similar result in that the people who attended got good results in percent body fat, and the control groups did not. Those who came less than 3 days per week were somewhere in between. So then we said, NIH had a request for a project that would extend for 3 years. I'm not sure what they had in mind, but I don't think it was an experimental design that they had in mind, but we believed in experimental designs. So we said, we're going to do an experiment that's going to last 3 years. I still to this day don't know if anybody's done that. So we randomized 18 schools. So talk about mileage, I was driving around to all the schools in Augusta, Georgia, making presentations and telling them about how wonderful research was and getting them to accept randomization into the 2 arms of the study. And you know what? I was impressed by the sophistication of the parents that they would allow themselves and their kids to be in projects where randomization was involved. And we, in our wisdom, asked NIH for $300,000 for a mobile unit. And we thought, well, they're going to say one of 2 things in the grant application. They're going to say, these people are crazy. They don't know about fiscal sanity. Or they're going to say they know how to do this better than anyone else. So yes, let's get this done the right way. So here's Zhenang Yin, was really the one who did most of the work on this study. He's now an endowed professor at the University of Texas. We measured body composition by DEXA. So we have, at this point, we had 3 DEXAs within our unit. And so we got good body composition measurements. We measured aerobic fitness with heart rate response. We did academic enrichment along with the snacks. This was a great part of the intervention. That's one of the reasons that it was accepted so well. We hired teachers to help them with their homework and give them academic enrichment activities. So they wouldn't complain that our kids are exercising when they should be home studying. We did get that complaint at times in the previous study. So again, they played ball games, rope jumping, and here are some of the results. Here's the first year. So here's the pre-test. Here's percent body fat. Here's the post-test, which would be in May and June, let's say. And you see a good result. Here's the control group, they went up. Here's the experimental schools, they went down a little bit, and it was significant. So that's good. 9-month intervention, clear results like that, we would say success, right? Unfortunately, the summer came along. It came back after the summer. No significant difference. This is for the second year. Well, that's not so good. What happens the second year? Hey, look at this. That's pretty good. The control group goes up, the experimental group goes down a little bit. Significant difference, 2 years in a row. That's great. But now we're wondering what's going to happen at the end of the summer. And what happens is they go back to being similar to each other. Anybody's doing an intervention, it has to be continued. Do it through the summer or in some way take that into account. And there's a paper that just came out summarizing several studies, including ours, showing weight gain, actually, in the summer that's greater than during the rest of the year. And then what about body mass index? That what I often say is not a good thing to measure. Well, we have height and weight, we can measure it, and sure enough, there's a significant effect over time. The time by group interaction is significant. One group has increased, not the first year, by the way, but in subsequent years. And which group is it? It's the intervention group. They built lean mass to such a degree that they actually were, if we had used body mass index as our index of obesity or adiposity, we would have concluded that our intervention made the kids fatter. But would that be a logical conclusion? Would that be a proper conclusion? No, I don't think so. And you can see the reason is the fat-free soft tissue goes up substantially more in the intervention group. The bone mass went up significantly more in that group. So what might happen to energy intake as a result of getting more lean mass? Well, as I mentioned, I'm just going to skip over this because of time, but some adult studies have shown that free-living physical activity is related, free-living energy intake is related to lean mass, not to fat mass and not to body mass index. Lean mass is critical. This is a group in the University of Leeds in England. So this is consistent with the developmental model that I suggested, where vigorous exercise increases lean mass, increases energy intake. So what's the status of the eat too much theory? Anybody want to guess? Well, if the theory says youths become fat because of excessive energy intake or insufficient moderate physical activity, the answer is no. The studies don't show that. As much as we like to believe that hypothesis, it's been falsified in I wouldn't say completely unequivocal terms, but it looks that way. So we bounce back up to the theory and we make a decision about how we're going to start or design a public health intervention? What should we put into that? Well, one thing we should not put into it is restricting dietary energy intake. And we shouldn't focus on moderate activity. For example, walking back and forth to school may not be sufficient. What's the status of the developmental theory? Well, you see me smiling because you know what I'm going to say. That vigorous physical activity and sufficient nutrient intake leads to better body composition. The research findings show that. The theory is not falsified. So the implication, when you bounce back up to the theory, is that the public health intervention should be designed to promote vigorous physical activity and appropriate diet composition to prevent obesity or promote leanness. So, and another aspect to this is that promoting vigorous activity is a positive message. Suggesting that kids not eat so much is not a positive message. And of course, vigorous exercise has a lot of other effects, including cognitive function. It's another interesting thing we don't have time to go into now, of course. But there's a whole book written by a psychiatrist called Spark, The Revolutionary New Science of Exercise and the Brain. Now, is there a danger of a physical activity overdose? Yes. And so we have to be careful, because high physical activity and poor diet, especially in, let's say, young runners and dancers. We studied women. That was one of the studies that Ron did not mention. We studied young women who were amenorrheic or eumenorrheic, and we found that high physical activity and a poor diet led to poor sex hormone levels, decrease in bone mass, and increase in fractures and musculoskeletal problems. So this is not good. You can do too much. You can be too thin. And if you add into that sports where you have stress, falls, and bumping into other people, the chance of a negative outcome is increased. So we can have this dose response where a low amount of exercise is not good, a moderate amount or up to vigorous exercise is good, but then you can go too far, and you want to avoid that, of course. So if we have this all incorporated into a comprehensive preventive intervention, we would say that we could focus on body composition and fitness, adequate doses of vigorous physical activity, like sports and dance for all, is very important. We should not emphasize reduced energy intake. We should encourage nutrient-rich diets. I haven't said much about this, but sunlight and vitamin D are important, and they come from outdoor play. And I think there's a confound between the vigorous physical activity and outdoor play. The kids who engaged in vigorous physical activity spent more time outdoors. So it may be working through the mechanism of the sunlight playing a role. Sitting is not a good time, not a good thing, and screen time can be overdone, of course. So here's a challenge for the next generation, of which there are many here. In fact, I dare say there's nobody of my generation here. We test deductions from various theories in the lab, in epidemiologic and public health settings, construct and test new theories that might be even better at explaining the data, and hope that you uncover some data that lead you to say, that's funny. And if you would like more information, I've been working with some colleagues on some review papers and have a book chapter coming out that summarizes the concept that it's the vigorous physical activity that really is primary. By the way, and I hasten to say, I did not start this area investigation thinking that we would I would end at that point. Thank you for your attention.
We want to present you, okay, you want to come, present you with the Spirit Award of 2015.
Thank you.
And while additional photos are being taken, I'd like the students in EHS 470 to go to the lunchroom. And everyone else, I would like to take the stairs to the poster presentations that are on the first floor terrace, or no stairs, 35, 45 on this floor, or one flight down, 25, 40. Thank you.